Welcome to ATCM, the Emergency Medicine Channel. Present in the case of a 68-year-old male who presented to ER with complaints of fever and generalized tiredness since one day. Along with, he had an unwitnessed fall at home with a decreased response, which occurred 30 minutes before the arrival to the ER. And initially, GRBS was also checked. It was about 40 milligram per deciliter, and oral sugar drinks was given. Oh. And after that, he had come to the ER.
What are the ways you can treat the hypoglycemia at home if your patient is a chronic follow-up of years? What are the ways you can treat? What are the ways you can train the bystander to treat hypoglycemia?
So you must always tell the bystander to look for the symptoms of hypoglycemia in water presentations.
Symptoms will be very difficult. No? Somebody will get unconsciousness in a diabetic patient. So for a layman, it will be very difficult to know whether it is hypoglycemia or hypoglycemia. Now we have glucometer, we can make out.
Yes. Okay. Always to carry sugar increased content drinks.
So sugar containing drinks or
chocolates
biscuits
or chocolates, toffees.
Okay, then.
Small frequent meals.
When you get a hypoglycemia, how to treat? Ideally, we should train all our bystanders to take glucagon. Okay. All patients must have one glucagon at least with them, so that immediately one shot of glucagon can be given at home. Because oral sugar, we don't know whether patient is unconscious, whether they can give or not. Sometimes it will be difficult. That's why this patient became unconscious and reached the hospital. And here we are checked and we are finding out it is very low. Yes. So that time is enough to damage his brain. Prolonged hypoglycemia is one of the reasons for brain damage. Okay, so if the bystander can be trained for this glucagon, then it will be very good.
So on initial 10-second assessment, the patient was conscious following the giving of the sugary feeds, and he was confused. And the airway was patent. There was no pooling of secretions or gurgling sounds, or stridor was not present. The breathing, the respiratory rate was 20 per minute, and the saturation was 95% in room air. And chest, there was presence of occasional clefts were present. And in circulation, the BP was 140/70 millimeters of mercury with a heart rate of 103 per minute and with a capillary refill time of 2 seconds. And the disability, the GCS was E3, V4, M5. And the GRBS, after rechecking, it was 187 milligram per deciliter. And on exposure, there was no presence of any rashes in the body, and the temperature was 100.4 degree Fahrenheit. So since the patient also is now currently febrile, we initially started on injection paracetamol 1 gram IV. Stat was initially given.
Tell me the indications for IV paracetamol.
Paracetamol is usually given in the cases of severe febrile episodes or in the case of as an
Tell me the indications for IV paracetamol. You had given nothing wrong in that, yes, but it may not be required. That's why I'm asking. Because 1 gram paracetamol IV may not be required at all. Most of the fever patients. One is pregnancy. Fever with pregnancy. Second. Fever with cardiac failure, fever with coronary artery disease, fever with stroke. Okay, these are the conditions we have to give paracetamol. Otherwise, paracetamol may not be required at all in most of the patients. In children, febrile seizures. Okay, all these conditions you are supposed to control the fever. Suppose you have a infection and fever is there. That's actually a protective mechanism. Only if the patient is having discomfort because of fever, then only you need to give paracetamol.
Yes. So after this, we taken adjuncts to the primary survey. We had taken a VBG, which was showing no acid-base imbalance, but with potassium of 4.7 and sodium of 139. Glucose was on 196, but it lactate of 4.5 and a creatinine of 1.78.
What are the reasons for high lactate here in this case?
So in this case, patient could be in a hypoxia could be associated.
Here there is no hypoxia.
No hypoxia. Seizure.
Here there is no seizure. What do you think? When the cell cannot metabolize or cell cannot produce energy due to whatever may be the reason, cell will go for alternative methods.
Yes.
Okay, here hypoglycemia is there.
Yes.
So cell is not getting adequate glucose to make a normal metabolic pathway. So it definitely will go for alternative pathway. So hypoglycemia, hypoxemia, low blood pressure, everything can produce hyperlactemia.
Yes.
Then seizure, it is because of something else. It is increased muscle activity, and hypoxemia together can produce lactic acidosis. Okay.
And we had also done a CBC-CRP point of care was done, showing a total count of 12,900 with an HB of 16 and a platelet count of 1,99,000, CRP of 13.1. And following which, with the sample history, 68-year-old female, male, who came to the ER with complaints of fever and generalized tiredness since one day, and had an administered fall at home, following which he developed a decreased response, and his GRBS was checked at home to be found of 40 milligram per deciliter.
So you believe that it is hypoglycemia?
Yes.
Okay.
And he was given...
Can hypoglycemia produce seizures, like you told?
Yes.
It
yes,
is
sir.
also possible.
Yes. And he was given oral sugary drinks, and his response got better after 5 minutes.
Okay.
But still, the patient following which the patient had developed one episode of vomiting. Yeah, which contained mostly food particles, which was non-bilious or non-blood stained. And there is no history of any breathing difficulty, cough, or headache, or running nose or associated. There is no history of any chest pain, palpitation, or any dyspnea or exertion associated, or orthopnea or PNT associated. There is no history of any abdominal pain or dysuria associated. And the allergic history, patient is not any allergic history. And medications, is regularly regularly taking pregabalin 25 mg along with the injection human actrapid 35 units at afternoon, and he was also taking a Beltam F tab, and also injection human Mextard was also he was taking at morning and at night, and also Ecosprin 75 mg and also Pan 40 mg. The past history, he's a known case of type 2 diabetes mellitus, and also history of prostatomegaly with GERD, and also history of had a history of atypical pneumonia 2 years back, and also has history of cervical spondylosis. Initially, because of his decreased sensorium, we had taken a neuroimaging. Initially, we had we had taken an MRI stroke protocol, and it was showing no acute infarct, and even the TOF there was no presence of occlusion of any vessels. And following which, we had taken a chest X-ray also. In chest X-ray, there was presence of bilateral increased bronchovascular markings and increased pulmonary infiltrates bilateral.
Okay.
And we had also done a USG, and it was showing mild fatty liver with no organomegaly. We had also taken the blood tests. Blood tests increase. Initially, the blood test, there was presence of raised HS trope of 0.260, and the CKMB initially was normal with a CRP of 14.64 and urea of 34.6 and creatinine of 1.90. And uric acid was 7.2. And
1.9 is creatinine, urea is only 30.
Yes. 34. Yes. And uric acid was 7.2, and SGOT of 48.8, SGPT of 38.3, and alkaline phosphatase of 54. And initially his URE was also normal, but his urine myoglobin it turned to be positive. Yes.
What are
After
the
2 days.
reasons for urine myoglobinuria?
So in the case of rhabdomyolysis is a possible. In the crush injuries to
This patient, crush injury?
No. So in this patient, he's having increased pulmonary infiltrates. So seizure could be.
If there is a seizure, definitely you get urine myoglobin. Like you told, crush injury. Here, uncontrolled muscle activities can produce muscle necrosis. So that may be the reason. Or we have to suspect some infections.
Yes, sir. After 2 days, we had repeated the CRP, sir, which rose to 226.12. And following which, initially itself, we had started on him on antibiotics of injection ceftriaxone 1 gram and azithromycin 500 milligram with fluor 75 mg BD. And so he was managed in, he was admitted in ER ICUs. And following during the stay at the ER ICU, we had also done the HRCT chest we had done. And the HRCT chest was showing scattered areas of ground glass opacities with bilaterally with the focal consolidation and central nodule in the bilateral lung, predominantly in the lower lobes. So suggestive of an infective etiology. That was the we suspected an atypical pneumonia. We suspected. So
what will you suspect? Don't tell atypical pneumonia first. Bilateral infiltrates are there in a diabetic patient admitted with altered behavior.
Yes.
What are the differential diagnoses you suspect? What is the common thing you will suspect? Common thing. Common is what?
Meningitis, fever with altered sensory.
Bilateral lung infiltrates. Viral pneumonia. Viral pneumonia is the most common thing. H1N1 COVID. Then only you suspect atypical pneumonias.
Yes.
Then Staphylococcus pneumonia. So bilateral infiltrates, there are a lot of differential diagnoses, including TB. But TB is not here there is no long history, it's only a short history. Fungal pneumonia, tuberculosis, viral pneumonia, atypical pneumonia, all these things are bilateral.
Yes. Initially we had done the culture, the blood culture and even a urine culture. Both had turned out to be negative. There was no growth. And also...
how much percentage of patients you get blood culture positive in pneumonia? Nearly 30% of the patients only you can get a positive blood culture. So there is no point in actually sending blood culture for pneumonia. You are not going to get it. Okay. Very rarely you get positivity in blood culture in pneumonia. Okay.
So then we had done atypical pneumonia panel also had been done, sir. It was showing...
What are the atypical organisms?
So atypical organisms mainly involves mycoplasma pneumonia and Legionella pneumonia and chlamydia is involved. And we can, the viruses like adenovirus or respiratory syncytial virus and presence of influenza B.
Okay. So what is the basic difference between atypical and typical?
It's mainly because the presentation of the patient.
What is the presentation difference?
In presentation, usually like it won't be only symptoms of breathing difficulty or onset of symptoms.
Okay, typical means cough, breathlessness, sputum production, hemoptysis, chills, rigors, consolidation. Atypical means no consolidation, bilateral infiltrates, mild fever, mild cough, mild breathlessness, then confusion, altered behavior, then hyponatremia, hemolysis, diarrhea. So the common findings. So other than typical findings, you get whatever you are getting with a pneumonia, you suspect atypical pneumonia.
Yes. So in this patient, he had a confusion also. So that's also one of the factors which are led to this patient. And according to the this curve 65 scoring system, so in the curve 65 scoring system, the initially itself he had a confusion, which was a new onset, so which of 1 point, and also had a blood urea nitrogen more than 20.
Urea is not high, urea is normal here.
Normally here.
R is respiratory rate. What is the rate?
Rate was 20 per minute.
20.
It was also normal.
BP
was also in the normal side. Age was more than 65.
Okay.
And so he was 2. So that was the curve 65 score for this patient. And So we are managed him on antibiotics. Then we had to hike up the antibiotics.
Why hike up? What are the antibiotics you use for a typical organism? Here, H influenza B is the organism.
Yes.
So, how do you treat atypical pneumonia? What antibiotics are required for H influenza?
So in case of influenza, we usually use antibiotics like ceftriaxone.
You are giving ceftriaxone here. Just continue that. That is more than sufficient.
Yes, sir.
Other atypical organisms?
We can use macrolides.
Azithromycin. Okay. What is the dose?
So 500
milligram. Once daily, twice daily.
Yes.
Once or twice?
Once. Once daily.
Once daily is enough.
Yes.
Okay. What is post-antibiotic effect? So azithromycin, clarithromycin, all these drugs we give 3 to 5 days maximum.
Yes.
3 days if you give, it will act for 7 days. So that will concentrate in the intracellular area and it will act for a longer time. Okay. So that is post-antibiotic effect. Most of these macrolides have this function. Okay. So you can give here, since the patient is sick, 5 days if you give, it may act for 8 to 10 days.
Yes.
Normal course, you give 3 days, it will act for 7 days. Okay.
Yes, we can also add a respiratory fluoroquinolone.
We can add, but last time we discussed an elderly patient had, like he had taken fluoroquinolone and he developed altered behavior. Okay. So quinolone psychos are very common in elderly individuals. So try to avoid this type of drugs in elderly individual. You can, safer drugs are there. You can give doxycycline, you can give azithromycin. Here you are giving ceftriaxone. All these things are good drugs.
Yes. And this is how we manage the patient, and his CRP now has also gone down, decreased from the initial rate, and now he's getting better. His infiltrates have also resolved.
Okay. How is the sugar control?
Diabetic.
Sugars are controlled or no?
Yes.
Okay. Only thing, when the patient is having hypoglycemic episode, you have to see review the drugs. Okay, there are some drugs which are long acting, especially when the creatinine is high. Yes. The drugs which are already there, like insulin, that can become a long acting, and sustained hypoglycemias are common. And when the patient is on some oral hypoglycemic agents, that itself can produce recurrent hypoglycemia. So you have to remove all these things. You try to go for a short acting insulin when the patient is in ICU. Okay. So that will give you a better control over the blood sugar values. Okay. Anything else you want to add?
So this is about the different organisms, and which as mentioned before, causing atypical pneumonia. And mainly if in Legionella pneumonia, mainly they are spread through the aerosols, mainly in the case of AC vents.
Okay.
And their symptoms also mainly involves
they present with diarrhea. Severe diarrhea.
Yes. And in case of mycoplasma, there will be a presence of, it's usually spread by infected respiratory droplets by contact. And it can lead to the possibility of hemolysis, encephalitis, even meningitis, and it can even present as stroke. And even carditis, so myocarditis and pericarditis can also occur in the case of mycoplasma. In the case of
what is aseptic meningitis? Aseptic meningitis.
In CS today, the culture
counts are elevated, proteins are elevated, but if you see the culture or PCR, it will be negative. So infection somewhere else, antibodies produce damage to the brain. So that is commonly called as aseptic meningitis. So this type of patients, you can get aseptic meningitis, encephalitis, all this thing. That there may not be direct invasion of the bacteria to the brain.
So in case of Coxiella burnetii, mainly cause the Q fever.
Okay.
Q fever mainly involves the fever, hepatitis, and also along with that, it will produce atypical pneumonia. So a triad of symptoms is usually produced by Coxiella. And then there is presence of chlamydia.
Okay.
Chlamydia trachomatis. So that's also we can use this cell culture PCR.
Okay.
PCR is used for its
Cell culture, we are not using PCR only.
PCR only we are using. And in case of chlamydia, then there's presence of Legionnaires disease. Legionnaires disease, along with it usually produces symptoms of pneumonia, cellulitis, and endocarditis like features. And also there's presence of Pontiac fever. Pontiac fever is usually like an immune reaction. It usually is a short term fever lasting for about 5 days. So the adenovirus and respiratory syncytial virus and influenza B and parainfluenza are the various viruses which cause atypical pneumonia. And,
How is the patient now?
yes, improved.
Okay.